Welcome, everybody. We're glad you could be here. Today, we're going to talk with you about a strategic planning process that we have used for creating comprehensive health and wellness plans in schools. Three of us are going to be speaking with you today about this topic. My name is Elaine. I am the director of the Center for Rural School Health and Education, and soon you'll be hearing from Dr. Ben Ingman, who's the director of research and evaluation, and Carla Lucky, who's our director of programming. Before we dive in, I want to let you know a little bit about our center. We're located at the University of Denver, and we partner with rural schools and school districts. Our vision is healthy, happy children and families living in vibrant rural communities. And our mission is to improve health and education outcomes. Here's a brief overview of where we're headed today. First, we're going to talk about why we do what we do, then how our planning process works, then what happened in the districts where it was implemented. And towards the end of our time together, we're going to share some tools that we've made available for you. And for those of you who are viewing this as a recorded version with our session at PD4HS, I want to let you know that we're available for questions after the fact. Our contact information is available at the end of the presentation. So first, a little bit about why we do what we do. We focus on rural students because they face a unique set of challenges, both in terms of their school context, which looks very different from suburban and urban districts, and their behaviors. So for example, rural students have higher rates of engaging in certain risky behaviors like substance use and high-risk sexual activity. And rural children also have higher suicide rates than others. There are many evidence-based practices schools can put into place to support students' health. The challenge is helping schools find a way to learn about, select, and get those practices in place. And that's where AIM comes in. AIM is our strategic planning process. We first developed and tested it in 2005, and we were able to show that schools who use AIM were able to implement and sustain more evidence-based practices than schools who used another tool. We've been using AIM ever since in different modes and with different populations, and continue to see that it works. Next up, I'd like to introduce to you Dr. Ben Ingman, who is going to tell you about how AIM works.
Thanks, Elaine. And as Elaine just mentioned, AIM is a strategic planning process to create district-level comprehensive health and wellness plans, or sometimes we say a CHWP, aligned with the whole school, whole community, whole child model. That's also sometimes abbreviated to be WSCC or WISC. So if we say that, that's what we mean. So just a closer look at this model before we get into the process. The aim here is that student in the middle, and we can achieve that through attention to those 10 components in that blue ring. Models like this are great, but in our experience, it's not enough to just give a school a model and ask them to make their students healthier. Many times they benefit from having a process to implement that model, and that's where that AIM process comes in. So I'd like to walk you through the AIM process a bit here, including who's involved, how it works, and what happens after the process, and some results we've seen lately. First, a bit about the key players. As you can see here, this green person is the AIM facilitator. That's someone from our center who guides the school district through the process. Next, this blue person is a wellness coordinator. That's someone hired at the district to coordinate the process from that side of the fence. We also train these wellness coordinators for this role. And then finally, you have that district task force. This is a group of people who cares about health and wellness in the schools and is recruited by the wellness coordinator and superintendent. We encourage the school to recruit a diverse task force, including teachers, students, principals, the superintendent, and community members. We've seen health department employees, doctors, nurses, mayors, school board members, business leaders, and all kinds of other roles serving on that task force. So in pulling this group together, they aim for broad expertise across the WISC model and diversity in community roles and backgrounds with a special focus on historically marginalized groups. So that's who's involved. Now here's a bit about how the process itself works. It starts with surveys of both the school and the students, In Colorado, we have SmartSource, which provides school-level data about the practices, policies, and procedures in the school. This is similar to the SHIPS that many of you may be familiar with. We also have Healthy Kids Colorado Survey, which provides student-level data about health behaviors, similar to the YRBS. If you don't live in Colorado, you can use SHIPS and YRBS to complete the AIM process. After those surveys are completed, they get started with meetings. We have here 3 task force meetings in which they assess, identify, and make it happen. During meeting 1, they look at survey data to assess the current status of student health and evidence-based practices across the 10 components of the WISC model in the schools. During meeting 2, they identify which health problems they want to focus on and which evidence-based practices they want to put into place in their schools. And then during meeting 3, they make it happen by developing that comprehensive health and wellness plan. These meetings are all facilitated by that green person there, the AIM facilitator, again, who comes from our center. Another major thread in the process is community engagement. This is spearheaded by the wellness coordinator, the blue person, along with the task force. There are 2 major touch points of community engagement. First, it's getting input from students and community members to make sure the plan will meet their needs. This is done through listening sessions, surveys, and community events. Second is the inventory of community resources. This is a chance for the task force to do some assets and resource mapping. We encourage attention to 3 perspectives in this. First, it's who's in the school who may be implementing the practices and could help out. Second, who are the partners outside the school that could help? And third, what financial resources might they access to implement the plan? And so then this is how it all fits together as one beautiful process. Those 3 task force meetings spaced throughout the school year, and then key outreach to the community occurs between those meetings. And then this process results in a comprehensive health and wellness plan that is informed by both data and the community. The wellness coordinator and task force create this plan with support from our center, and we provide a template to complete these plans, which I'm showing you here, as well as technical support in populating the plan kind of on an as-needed basis. Now just a bit about what's included in these plans. There's a background section of where the plan came from, the vision statement for wellness in the district, the student health problems of focus, evidence-based practices aligned to the whole school, whole community, whole child components, action plans, and accountability and sustainability plans. So I know you're wondering, what happens then? Well, they implement the plan. Most plans are built out on a 5-year implementation schedule. So the task force leads the charge of implementation here, with our center providing ongoing support and guidance. So that's the process. In a nutshell, starting with some surveys, pulling together a school district task force who is guided through a series of meetings by a facilitator. Through those meetings, they assess what's going on with students and in the schools, identify some evidence-based practices to put into place, and then make it happen by creating that CHWP, or Comprehensive Health and Wellness Plan. The task force and wellness coordinator also reach out to the community to get input and to leverage resources to implement the plan they create. This process was completed in 1 academic year for each district, with a 5-year schedule of implementation to follow. That is how the process works. Now I'd like to talk a little bit about how this played out in Colorado over the last couple of years with support from the Colorado Health Foundation. So this here is a map of Colorado. This red line is the area we targeted. This is a rural frontier region with the highest childhood poverty and lowest county health rankings in the state of Colorado. Just to bring it to life a bit here, you can see to the west is the San Luis Valley, which is a high altitude basin at about 7,500 feet in elevation. Southeastern Colorado is to the east of the mountains. It's mostly plains, and this is where the Comanche National Grasslands is. So they're both beautiful in their own way, and together this region is about the size of West Virginia. We were able to partner with 27 school districts in this region. As you can see, those districts serve over 12,000 students. Just some key demographic info here, about 64% of students are enrolled in free and reduced lunch, and 50% of students identify as Hispanic. Now I have some photos to hopefully help bring the process to life a bit, here we have a task force learning about the WSCC model during the assess meeting, again, that first meeting. Here they are crafting a vision statement for their work together, again, during assess. Here they are reviewing student data. So for example, the percentage of students who have felt sad, hopeless, or depressed in the last 2 weeks is a data point they might be looking at. Here they are during identify, prioritizing student health problems. So for example, they might be deciding they want to focus their plan on poor mental health rather than physical inactivity. During identify, they also select evidence-based practices to include in the plan. Task forces typically break into small groups to focus on an individual health problem and then select practices from across the WSCC model that will address the problem they are working on. For example, if they are working on the health problem of poor nutrition, they might decide to include breakfast in the classroom or cooking classes with families or providing healthy snacks throughout the school day as practices to include in their plan. This is an activity during Identify where we use this giant sticky wall to identify which practices are included in the plan and to verify that the practices included in that plan align with the health problems. It's organized by WISC component up top there, so they can see, visually quickly which components they're heavy or light on, and they can also participate in creating something together. Again, identifying practices across the WISC model to address the health problems of concern. This is a task force during Make It Happen, mapping resources to determine what they might leverage in their community to help them implement practices across their plan. Also during Make It Happen here, this task force is reviewing implementation guidance, a guide we created to help folks think through the various steps of implementation. So for example, getting buy-in from key stakeholders, purchasing necessary materials, or writing the change into school policy. And then finally, here's a task force creating action plans. These plans clarify who will champion each practice and the resources they have to draw on to get it done, specifically thinking about funding, partnerships, and key implementers. We also wanted to share some of the key outcomes of this effort, which are the health problems and practices selected in comprehensive health and wellness plans, and our approach to tracking implementation of those practices. I'm just going to touch on each of those briefly here. So as a reminder, each school district selected 2 to 5 student health problems to include in their CHWP. This graph is showing how many school districts selected each health problem. So a bar going all the way to the right there would mean that every district included that problem in their plan. The key takeaway here is that poor mental health and alcohol, tobacco, and other drug use were selected as health problems by most task forces, with almost all task forces including poor mental health as a focus of their plan. This is a graph about the evidence-based practices that were included in district plans. So I'll start you down here in the lower left corner where you can see that 644 total practices were included across the 27 district plans, which is an average of 24 practices per district. And then this bar graph is showing which type of practices tended to be in those plans as organized by WSCC component. So you remember that blue ring from the WISC model, those are the components I'm referencing here. The message to take away from this one is the most popular component areas were counseling, psychological and social services, and health education. So just lots of practices in those areas in these plans. We're also helping school districts track the implementation of practices over time and providing technical assistance to those school districts. What I'm showing you here is our implementation tracker. It's just a handy way of tracking an evidence-based practice. Sorry, if an evidence-based practice is not implemented, partially implemented, or fully implemented, so that we can help provide targeted support if a district is having trouble implementing a certain practice. With that, I'm going to hand it off to Carla, who's going to let you know about a few resources we have available.
Thanks, Ben. As Ben said, I'm going to share a few resources that you can access for free. The AIM Do-It-Yourself Guide, which is a simplified version of the AIM process, and the CHWP template, which is a template you can use to create your own comprehensive health and wellness plan. We will provide links to each of these resources at the end of the presentation. The first resource I'm going to share with you is the AIM Do-It-Yourself Guide. Although we ran a highly facilitated process, we want people to be able to apply these ideas in their own settings, and that's why we created this guide. Again, we're going to provide links to these, so right now I just want to give you a high-level overview of what's included in the guide. In the Do-It-Yourself Guide, we include key aspects of the process in a simplified format that we hope can be applied in a variety of settings. For example, here, tasks to include before the first meeting include gathering data and putting together your task force. There are also tools available to help you do these things. So this task force recruitment guide, for example, will help ensure diversity of perspectives, backgrounds, and expertise on your task force. We provide a list of activities for the task force to complete during each step of the process, assess, identify, and make it happen. And guidance about how to include students and the community throughout the process. And this includes a link to a survey and listening session guide, which you can see there in the red text. Also included in this guide is an implementation checklist, which offers suggestions for how to go about putting practices into place. And this is based on the literature of implementation science and our expertise partnering with rural schools over time. The other resource we have available for you is the Comprehensive Health and Wellness Plan template. Again, I'm going to give you just a high-level overview of what's included in this. The CHWP template includes background information about who, what, and why the plan was created. It provides data related to student health and the school environment, which illustrates how the task force came to their decisions about which health problems they will focus on. The template also includes space to list the practices the district will implement related to the different components of the WSCC, as well as a timeline for doing so. And finally, the CHWP lays out the intentions of the task force moving forward to support implementation of the plan. And this includes things like identifying champions, sharing the plan with a wide audience, and evaluation and accountability procedures. So as we mentioned, you can access both of these resources at the links on the screen and through the conference's virtual platform under the files section for this session. And with that, I'm going to pass things back over to Ben to close out.
Awesome. Thanks, Carla. And we would love to be able to bring AIM to other states and regions. So if you think your state or community would be interested in tackling a comprehensive approach to health and wellness in a school, please reach out to us so we can brainstorm how we might be able to partner. And with that, for those of you who are with us live at PD4HS, we'll invite your questions at this time. And those of you viewing a recorded version of this, please do not hesitate to reach out to us. You have our contact information there, along with the links to the resources Carla just reviewed. Also, a huge thank you to Carla and Elaine. I couldn't, I feel very, very, very lucky to be working on such a competent and amazing team. And thanks to all of you for joining us. And I want to thank the PD4HS team for their awesome support in bringing this presentation together. So with that, we'll close out and hope to hear from you.